Hello. Could I encourage everybody to sit down? Mine's on. Okay, I think everybody is hopefully starting to take their seats, and we will get going. Okay. Okay, for everybody walking in, please could I ask the final few people to find a seat, and for everybody else to quieten down. That would be fantastic. Welcome to the UK Myeloma Society Autumn Day. My name is Charlotte Paulin. I'm a haematologist from the Royal Marsden Hospital and the Institute of Cancer Research in London, and my co-chair is
Karhik Ramasamy. I'm a haematologist and a researcher at Oxford.
So we've got a really packed and hopefully interesting agenda to get through today, but so we're going to try and start and keep to time as we go. Before we do start, just a few pieces of housekeeping. We are joined by a lot of people online. I think we're up to about 60. We're expecting about 80 people online, along with everybody in this packed room. So delighted to have you all with us for the day. I'd like to thank all of the sponsors who are providing support for the meeting. So Binding Site, Menarini Stemline, J&J, Pfizer, GSK, Sanofi, Bristol Myers Squibb, Amgen, Gilead Kite, Adaptive Biotechnologies, Takeda, and Cellcentric. Thank you very much for your support, and please could I encourage everybody to talk with them at the breaks, over coffee, over lunch. That can often be very, very useful for you as well as for them. So please do that. The other thing is that because we have an online audience, please, if you're asking a question, wait for a microphone to come to you so that the online audience can hear what you're asking. If the fire alarm goes off today, this is not a test. There are no planned fire alarm tests. And I think that is all of the logistics for the day. So we're going to start with my co-chair, Karthik, giving us an update on UK practice and access updates.
Good morning, everybody. Great to see so many of you here in the auditorium, as well as so many people online. One of the kind of busiest meeting that we have held, but it's great to see that UK Myeloma Society has a space in your education, which is exactly what we as a society intend to do. This is the overview of what I'm going to go through over the next 20 minutes. I'm going to start with changes in current clinical practice. Hopefully I've got all of those right, because myeloma treatments change on a weekly basis. Then I'm going to give you a perspective of where changes to treatment pathway would look like in 2026, and that's very much about access to new therapies. I'm going to talk about changes in diagnostic practice and how that would influence our clinical care. And I'm going to finish up with clinical trials, because as you can see, UK Myeloma Society role is to improve the care of patients through education and promotion of trials. So that's integral to what the society does. This is a current UK treatment landscape. I looked at Kerry's slides from spring, and the only two key changes that I have identified, I'm sure my colleagues may find others, is we have isatuximab VRD for newly diagnosed patients, and we also have belantamab mafodotin Velcade Dex. This is a fairly complicated slide trying to integrate what the UK treatment landscape looks like. And as you would appreciate, there's a fair degree of variability of access as well. Hopefully not for too long, and things will continually change over time. But you will appreciate that the treatment landscape is complicated, and therefore I think MDTs are getting more challenging. But we are grateful that there are choices that we can make, and patients can drive some of these choices in discussion with all of you. So the two key changes, as I've highlighted, is isatuximab in combination with VRD for untreated myeloma for transplant-ineligible patients. And I couldn't believe this article NICE put out saying NICE leads the way in approving breakthrough treatment for multiple myeloma. I think they're very glad that they did do a kind of world's first, which is great to see. So why are we excited about ESA-VRD for transplant-eligible newly diagnosed multiple myeloma? I think these are my summary thoughts. It's the first quadruplet therapy for newly diagnosed myeloma, transplant-ineligible. Clearly, there's a deeper remission noted in comparison with triplet therapy, and that is the BENEFIT trial, which was published in Nature Medicine by Xavier Leloup. Because you do get higher MRD negativity rates. And the projected progression-free survival in these transplant-ineligible newly diagnosed myeloma is 90 months. And for somebody who is over the age of 70, I think this is very good. So exciting times. So why are we excited about belantamab mafodotin, bortezomib, dexamethasone, and we'll hear Kevin Boyd talk today about ADC approaches. And this is currently only approved for patients with prior lenalidomide exposure. I'm sure there's a more technical wording, but I just said prior lenalidomide exposure. Why are we excited? We now have the ability to give BCMA-targeted therapy in early relapse, and this space is going to change. Why are we excited again? It showed improved overall survival in comparison to daratumumab vedotin, which was our primary second-line therapy for patients. Third, patients can also receive BCMA-targeted therapy after receiving belantamab mafodotin second-line therapy. So that's another opportunity that we have. But that's why we've invited Paolo Neri today from Calgary to give us some sort of kind of conceptual ideas about what does this mean for clinical practice with some seminal observations Paola and her team have made in Calgary. What are the changes to the treatment pathway expected in 2026? Again, I apologize if there's anything that I've missed out, but the major changes that I have seen in the newly diagnosed myeloma setting is we're now going to have daratumumab, hopefully, when approved, daratumumab, bortezomib, lenalidomide, dexamethasone, another quadruplet for patients with newly diagnosed myeloma when stem cell transplant is unsuitable. So that is one approval. So the same quadruplet therapy followed by stem cell transplant and then daratumumab, lenalidomide maintenance for patients who are transplant eligible is also hoped in 2026 to kind of get through. So, upfront significant changes. So quadruplets pretty much everywhere is what we will have in the UK. What are the additional changes expected in 2026? We had a nice meeting yesterday on belantamab mafodotin with pomalidomide and dexamethasone for previously treated multiple myeloma, and we are expecting an outcome to come through, maybe even before the end of the year or early next year. Belantamab mafodotin combination with Velcade-Dex is also looked at for lenalidomide-naive patient population. That discussion is ongoing, and again, we are hoping to hear either by the end of the year or early next year. So we're going to have potentially two combinations of belantamab mafodotin in early relapse. Currently, we're having talquetamab, which is GPRC5D targeted bispecific antibody going through the NICE pathway for patients who've had 3 prior treatments. And the positioning currently looks like you could have a choice of whether you want to go GPRC5D bispecific or a BCMA bispecific in this setting. And again, that is important from a clinical practice perspective. And again, thoughts we'll hear from Paula will be helpful in kind of shaping some of our concepts around choice around the kind of fourth-line therapy. So that's around current clinical practice and what changes are anticipated in 2026. And I do hope somebody will stand here and talk about giving CAR-T in 2027 for patients in the UK. We really genuinely hope that companies will take their products to the NICE team in due course. The two key changes in diagnostic practice we're expecting, one is around genomics, second is around MRD assessment. So why should we be thinking about genomics? Well, there is a new high-risk myeloma definition that's been published in JCO. in April of this year from the IMS, IMWG working group on high-risk myeloma. So you should be doing the genomics in sorted cells, so 20% or more del17P. You have to do a TP53 mutation. I'm aware some people do it in like a cancer panel within their local hospital, so that's now expected. There's no threshold VAF for that. Biallelic del1P is a high-risk feature. And I know some labs, when we started out with radar, we found out that many labs didn't do 1420. So now that would be expected if you want to find those two or more features that you see here, that'll be coupled up. And if you have a beta-2 microglobulin of more than 5.5 and none of these genetic features, and your creatinine is more than 106 in our language, would also be kind of a high-risk feature in patients. So if you want to identify your high-risk patients, then you've got to think about how your genomic testing is currently working for you. What we've done in RADAR, led by Eileen and Sarah, is started looking at whether RADAR samples, which, as you know, is a genomically stratified trial for high-risk patients and different treatment program for standard-risk patients. Already we're starting to observe that we can get greater granularity by using the myeloma genome panel, which is what Sarah has shown here, and this was presented at ASH 2024. But to me, what was more interesting was if you apply the new IMS, IMWG criteria, and now you've got TP53 mutation and the kind of double hit features, then we certainly are able to identify more high-risk patients. Well, obviously we have quadruplet therapy for all patients, which is great, but whether in the future we would have differential approaches to these patients, well, wait and see what the RADAR data that I'm going to present shows at ASH, and all of that is exciting. But historically, both Matt Jenner and Martin Kaiser have already highlighted that these type of patients would require a very kind of differential approach to treatment. So that's genomics. Well, when can we do all of this? There's some efforts led by Angela Hamblin, working with the Salisbury Lab and Matt Jenner to work collaboratively across the network. And work is ongoing to get an ISO assessment done later this month. It's kind of all best laid plans, right? You know, they all start shifting after a period of time. But certainly there's a go-live date plan in 2026, and hopefully all of your GLHs should be able to do MGP in your centers. But I am aware that TP53 mutation can be done through cancer panels, and that can potentially be an add-on to FISH if you have. So that's genomics, and it's important to kind of stay close to those changes and be able to identify those high-risk patients in your practice. Next is MRD. We've always wondered about doing MRD in clinical practice because we weren't making much in the way of clinical decisions, but there will be one. We hope that Perseus, which is the DVRD followed by DR maintenance, will be the first therapy which will be MRD-driven. And you can see here in this slide, you could discontinue data therapy after 24 months if patients are CR and 12 months of sustained MRD negativity. So when the NICE approval comes through, we expect that that's the tag that it will come through. Therefore, you would have to do MRD testing in your patient. So what type of MRD testing? But before that, you can see that the proportion of patients who have sustained MRD negativity at 24 months here is substantial. So almost 1 in 2 patients will stop daratumumab. Therefore, doing MRD testing would be absolutely essential as part of your care. All of this work in Perseus trial was done through NGS. But in RADAR, we've been doing all of this centrally with our leads lab, who lead all of our frontline trials from an MRD testing perspective by flow. And the submission currently will open it up to all methodologies, and you will all start to look at how you will deliver flow-based or an NGS-based kind of methodology in your locality, and I'm sure it'll be an active point of discussion in your clinical practice. Just a few thoughts to run with you. Obviously, blood-based MRD is gaining momentum, and this is the first approved technology that is out there. where you are looking at the kind of mass spectra of these paraproteins, and by looking at this, you do get a greater sensitivity than your standard serum protein electrophoresis and serum immunofixation. And in the RADAR trial, all the time points where we're doing flow MRD, led by Kerry and Ejun, we now have a CIUK funding to do UKMS at these time points, both for standard risk patients and for high-risk patients. So hopefully we'll have some data, and potentially in the future we could be looking at blood-based testing for patients, not just to stop therapy, but also to continue to monitor our patients closely. So finally, to finish off the 3 clinical trials, this is the RADAR trial. Thankfully, we have now 1,275 patients out of 1,400 patients. So there are less than 125 slots to go, and this trial is closing December of 2025. We have recruited enough patients in the high-risk arm already of the high-risk version 7. So we're hoping that more of you will continue to recruit in these 2 months into the standard risk arm so that we have a better understanding of stopping therapy. So we intend to stop therapy. Remember, this is very different to what you have in Perseus trial. We intend to stop therapy in sustained MRD negative patients and look at what their outcome looks like. The 2 trials that are currently being prepared and will be recruiting. The first is the Optimmune trial led by Matt and Martin, and this will recruit in Q2, Q3 2026, and we're bringing forward BCMA bispecific therapies into the frontline setting. So quads are great, but what can BCMA bispecific antibody do in the frontline setting? There's a real focus around replacing transplant as well as reducing infections with improved supportive care. So very novel design, as you can see. So please do look out for those emails around feasibility and potentially joining these efforts. And my final trial slide, and this is led by Charlotte, my co-chair, with Gordon Cook at Leeds. This is the IFIT trial, and this is now through MHRA and ethics, and we'll be actively talking to sites to set up. And you can see the concept again is around MRD driven, but also to bring forward treatments such as teclistamab and talquetamab to newly diagnosed patients to drive deeper remissions in patients. So to summarize, we currently have new options in the form of ISA-VRD and Bela-VD for patients. In 2026, Bela-VD for len-naive, BPD, DVRD for across the board for newly diagnosed patients. Talquetamab hopefully will come through. Genomic testing and MRD testing, you've got to get yourself set up as a center, and you need to have a local cancer alliance solution. And please continue to recruit to multi-center newly diagnosed myeloma trials. I hope I've kept to time. Thank you.
Fantastic, Karthik, for taking us through all of that. For those of you standing at the back, there are lots of seats at the edges of most of the rows at the front, so please do make your way forwards. Otherwise, you'll be standing for a while. Perfect. So we're going to move on to